Okay, so today we're going to talk about melanocytic neoplasms. This corresponds to chapter 6 of the Elston textbook. So here's our first one, and you have elongated reedy ridges that are pigmented, and there's a normal or a slight increased number of melanocytes. And you may see solar elastosis in the dermis. It's kind of hard to tell here. This isn't necessarily a true melanocytic neoplasm, but this is a pigmented lesion. So this is a solar lentigo. This is what they're talking about when they say like dirty socks appearance or dipped in chocolate look. And then you may or may not have an increased number of melanocytes. And clinically, they're just tan macules in sun exposed areas. Okay, next one. So we're somewhere with a lot of sebaceous glands, and we just have increased pigmentation at the basal layer, but it doesn't look like there's any melanocytes forming nests, and there's no increased number of melanocytes, or at least it doesn't seem like it. So this is just a melanotic macule. This is commonly seen on the lips and in the genital area. You may have thickening of the epidermis, and you may have a subtle increase in the number of melanocytes, but the main thing is the redi are broad and squared off with pigmentation at the basal layer, and it's usually seen in adults over 40 years old. Okay, next one. So we have melanocytes forming nests, and they're getting smaller as they go deeper down, which is called maturation. And they all look pretty uniform. Well, they're getting smaller, but in each nest, they look uniform. So this is a benign melanocytic nevus. So it should be well nested. It should be either at the tips or the sides of the reedy ridges, and then matures with depth as it goes deeper into the dermis. So the most common mutation associated with benign melanocytic nevi is BRAF, then NRAS. And you can see eruptive acquired nevi in conditions like epidermolysis bullosa or lichen sclerosis, and they can be at any site, but certain sites have some special features, which we'll talk about. Okay, this is from the Elston textbook comparing nevi to melanoma, but we'll talk more about this as we go through. Okay, so in this case, we have a lot of these large melanocytes that are a little bit more foamy or vacuolated, but then we also have some more like typical nevi cells. So, and they all look pretty uniform. So this is a balloon cell nevus. So clinically, they look the same as any other nevus, but they have these large pale polygonal melanocytes with variable pigmentation. But they still mature with depth, and you still don't see any mitoses deep, and it's still well defined. Okay, similar kind of thing, but here you can see the melanocytes kind of following these blood vessels around and tracking along them. So this is just a congenital nevus. So they track down follicles, vessels, nerves, but they still mature with depth and they can be a lot bigger. So most common mutation in this is NRAS, then BRAF, and they can be small, medium, large. So you have an increased risk for melanoma if you have one large congenital nevus or three or more medium-sized ones. And you can get proliferative nodules within congenital nevi that can mimic melanoma. And then you can also, associated with this, get melanosis of your meninges, which we'll talk about in a second. So if you have a large posterior axial congenital nevus or multiple satellite nevi, you should get an MRI to screen for neurocutaneous melanosis, to make sure you don't have it on the meninges. And then they need serial examinations and biopsies of any nodular areas. Okay. So this one has some larger epithelioid, I should say, melanocytes, but they're still well nested. So this is a Spitz nevus. And you may see pseudoepitheliomatous hyperplasia or hypergranulosis, but they're well nested at the DEJ. And the nests are a lot of times more vertically oriented, which some people call like the bananas on the tree. I guess what they're talking about is like this kind of looks like a bundle of bananas, like it's more vertical than how they normally are. Um, and then you can see clefts around the nest. You can also see camino bodies, which I have a picture of in just a second. And then the nuclei are usually larger with more prominent nucleoli. So these are camino bodies. They contain basement membrane material and they stain positive with PAS. So clinically, they present as a pink red papilla nodule. And the most common mutation is an HRAS mutation, but there's some other stains that you can use for this. The treatment is somewhat controversial, but generally it's recommended to completely excise these. And then there's some different genetics that may be present that may, you know, be more associated with poor outcomes or associated with melanoma. Okay. Kind of similar looking, but more heavily pigmented. So this is a pigmented spindle cell nevus of Reed, and you can also tell that the cells are a little bit more spindly. And these are more commonly on the leg. So they're heavily pigmented, um, and they're usually small on the thigh of a young female. And here's another chart from the Elston textbook comparing spindle cell, or yeah, spindle cell nevus of Reed and Spitz nevi. So they're less likely to have communal bodies, but they can. Okay. So for this one, you can tell that we're on acral skin because we see the lamina lucida and we have this thick, compact stratum corneum. And then we have nests of melanocytes that all look like they're at the tips of the reedy ridges. So this is just an acral nevus, and it might look a little funky, but this is just what acral nevi look like. And they tend to follow the dermatoglyphs, which is like your fingerprint. And they should just be at the DEJ. And it matures with depth if it is deeper. And again, like the other ones, there's no deep mitoses, no deep pigment. Okay, so this one, you can tell a little bit better when you're on this close-up one. So you have your melanocytes, but then you also have a lot of lymphocytes mixed in here. So, but it's a well-defined lesion overall. So this is a halo nevus. So you get this band-like lymphoid infiltrate throughout the whole thing, but it's still well nested. It's still maturing with depth. It's still a well-defined lesion overall. And then clinically, you have a nevus with a hypopigmented zone around it. It's most commonly in the second decade of life and frequently on the back. And it can be associated with vitiligo or melanoma at another site. So it's not melanoma at that spot, but like somewhere else. And then sometimes these can be associated with certain medications like infliximab or pembrolizumab. And the lymphocytes are intertwined with the melanocytes versus if it was melanoma, the lymphocytes would be all under the melanoma. But here they're all mixed together. Okay, this one. So our main action is here. So you can tell it's a well-defined lesion. And you have these spindly melanocytes. So this one, and also you can, this is probably on a scalp because there's a lot of hair follicles. So this is a blue nevus. So this has like those kind of spindly melanocytes, and typically there's this sclerotic red stroma, which you can see here. Like the stroma here is more red than the stroma like here. So that is seen in blue nevi too. So clinically, it's most often on the scalp and sacral area, but also the distal extensor extremities. And it's just a homogeneous blue papule or macule. And multiple blue nevi and epithelioid blue nevi are associated with Carney complex. And the most common mutations are GNAC and GNA11. So there's some different variants as well, which we have a picture here. So common blue nevus is kind of wedge shaped, more superficial. Cellular blue nevus has this like dumbbell shape to it. So that's how you can distinguish those two most commonly. Sorry, trying to go back to this slide here too. And then the cellular blue nevi are more likely on the buttocks or the scalp, and it's just a denser proliferation of plump, pale gray melanocytes, and it bulges into the subq. Versus the common blue nevus is those elongated dendritic melanocytes in the upper two-thirds of the dermis. And then the epithelioid ones, like I said, are associated with Carney complex and they're heavily pigmented. And then when it's malignant, you'll see deeper extension of the tumor, necrosis, and mitotic figures. Okay, so this one kind of looks similar, but as you can see, it's penetrating deeply into the dermis and maybe even into the subq here. So this one is a deep penetrating nevus. So you have a compound melanocytic proliferation with a small junctional component, but then it goes deep into the dermis and tracks along adnexal structures. And this is related to activating beta-catenin mutations, which increases cyclin D1. And these are most commonly on the face, upper trunk, and extremities, and in the second or third decade of life. Okay. So this one, up here, we have kind of like one of those Spitz nevi with the big epithelioid cells. But here we have more of like a traditional intradermal nevus. So when you have two different kinds of nevi or two different kinds of melanocytes, that is a combined nevus. So just basically two types of nevi combined into one lesion. Okay, so this one is from a glance, if you just looked at this side, you would probably just think like an intradermal nevus. But if you look up close, these are a little bit more of like larger, more glassy kind of melanocytes. So this is a bapoma. And this is a unique kind of combined nevus where you have these epithelioid nevus cells with like a normal run-of-the-mill nevus. So there might be a hyperchromasia and pleomorphism or boomerang-shaped nuclei. And then there might be a couple mitotic figures, but there is retention of elastic fibers as well. And there's strong expression of P16 and then a loss of BAP1. And their behavior is benign, but they do occur with other malignancies. So this is associated with the loss of the BAP1 tumor suppressor and activating BRAF mutations. So in that syndrome, the BAP-related tumor syndrome, you get these bapomas, malignant blue nevi, mesothelioma, and uveal melanoma. Okay, so again, we have nests of melanocytes that are mainly at the tips and the sides of the reedy ridges, but we also have some bridging of adjacent reedy ridges. We have some fibroplasia in the papillary dermis. So this is a dysplastic nevus. So big things to know about this is you can get club-shaped hyperplasia of the reedy. You get shouldering. So what shouldering means, let me see if you can see it here. Kind of. So basically, shouldering is that your junctional component goes at least three reedy ridges beyond your dermal component. So there's like a shoulder of junctional component on either side. And then you also see the nest of melanocytes at the tips and sides of reedy ridges and concentric papillary dermal fibrosis. Okay. So the current grading is low, moderate, high. There is a WHO kind of movement to just go from just to do like low risk, high risk. But I think a lot of people are still doing like mild, moderate, severe. There's different ways of grading it, and it kind of is subjective in some ways. So these can also occur in the FAM syndrome, so familial atypical multiple mole melanoma syndrome, or it can just be spontaneously. But for FAM, that's a mutation in the CDKN2A gene, which encodes P16 and P14. And then when patients have like a signature nevus pattern, the ugly duckling is usually the melanoma. So you should biopsy anything that doesn't look like their typical moles. And then most people do observation for mild or moderate nevi, dysplastic nevi, and then re-excision for severe dysplastic nevi. Okay, so kind of like in the blue nevus, we have those spindle dendritic melanocytes, but we don't have as much of like that sclerotic um, stroma here, and then like it's also not as well defined. So this is nevus of Ito or Oda. So nevus of Oda is when it's on the face, Ito is when it's on the shoulder, and then Hori's nevus is when it's bilateral on the face, but they're all kind of related. So you have these dendritic melanocytes between collagen bundles in the upper third of the dermis, and you don't have that sclerotic stroma, like I said. And then congenital dermal melanocytosis looks similar, but this is in the lower two-thirds of the dermis, so a little bit deeper. And then this presents in the first year of life or around puberty. And it's just gray-blue macules that are coalescing. For nevus of Oda, it's unilateral and usually around the eye. And you have an increased risk of glaucoma with this. And it can rarely degenerate to uveal melanoma. And that's because you have the GNAC mutation. And then, like I said, Hori's nevus is the same kind of thing, but on both sides. And then Sun's nevus is the unilateral variant of a Hori nevus, and it's acquired. And then nevus of Ito is the same, but it's on the shoulder or supraclavicular area, and this has no risk of progressing to melanoma. Okay, time for the grand finale. So this one we have nests of different sizes and shapes, and the cells look larger than normal. And there's some nuclear pleomorphism going on. So this is melanoma, which we'll get into some of the different subtypes, but big things to look for is that the nests are irregularly shaped, irregularly spaced. They're everywhere. You might have areas of confluence of melanocytes. You can have atypia, mitoses, and the lesion itself is not symmetric. Okay. So these are some of the high risk mutations with melanoma. So BRAF is usually superficial spreading melanoma. NRAS is nodular melanoma. CKIT is acral and mucosal melanoma. GNAC or GNA11 is uveal melanoma. And then BAP, like we talked about, is those the uveal melanoma, but also the BAPomas. Okay. So this one, you can see that you have a regular nest and you have some pagetoid spread of your melanocytes, which means it's going up into the epidermis. And then the nests are just like, oops, sorry, wasn't trying to draw that. And the nests are just kind of irregularly spaced, different sizes. So this is kind of like the typical melanoma. This is superficial spreading melanoma, so it's usually a broad lesion. And you can have the buckshot scatter of atypical melanocytes, which is like kind of like the pagetoid spread, and nests are not evenly spaced. Um, and then HMB45 staining is typically strongest at the base, and then you can also have S100 staining. Yeah. And then you might have that lymphoid infiltrate at the base, kind of walling it off. So they call that like the riot police. And the most common mutation in this is BRAF. And it's the most common subtype. Okay. This one, you can see that the melanocytes are all coalescing here at the DEJ. And then you have a lot of solar elastosis. So this one is lentigo maligna, which I kind of think of as like it's like a lentigo, but there's a ton of melanocytes that are all just coalescing at the DEJ. Um, and then if it goes into the dermis, then it's lentigo maligna melanoma, but lentigo maligna is more of like a melanoma in situ. And then mutations that you can see in this are NF1, NRAS, CKIT, CCND1, CDK4, and it's on chronically sun damaged skin. Okay, so this one is more of like those spindly kind of melanoma or melanocytes. So this is spindle cell melanoma. So this is in the SLAM differential, which other things in the SLAM differential are spindled SCC, leiomyosarcoma, um, atypical fibroxanthoma, AFX, and spindle cell melanoma. And this HMB45 is going to be negative. So the most reliable immunostains in this are S100 and SOX10. And this is when you have a spindle cell proliferation kind of slammed up against the epidermis. Okay, this one, so again, we have atypical Nessa melanocytes and confluence, but then we have all of this fibrosis. So this is desmoplastic melanoma. And again, kind of like the spindle cell melanoma, HMB45 and Melan are unreliable, but S100 and SOX10 are generally reliable, and you get this desmoplasia around it. Okay, this one, you're really just seeing like big nodules of melanocytes that are atypical. So this is nodular melanoma. Um, And this one is most associated with the NRAS mutation, so N for nodular or NRAS. And it's most commonly on the head and neck and back, and more common in men. And you get a rapidly growing blue-black nodule. Okay, so this one's a tricky one. Again, you see this confluence of melanocytes at the DEJ. But then you have these areas where it kind of looks like maybe something was going on here before, but it kind of went away. So this is regressing melanoma, and you might see lichenoid infiltrate, and you can see fibrosis and melanophages. And this is an adverse prognostic indicator, so it's associated with worse prognosis. And that is it. Thank you.